All right, thanks. I'm thrilled to be here. I was so honored. I contributed some money last night to the Arizona economy. I did it out there. So good. Gave a little back, giving back. I'm from Arkansas, therefore, by nature, I have nothing to disclose. I mean, you know what I'm saying. So I'm old, and there are a few people my age or older in the audience, and this is the way we grew up. Your worth as a medical student was how hard you could squeeze the bag of crystalloid and how many you could get. I got in 4. I only got in 2. Well, you were clearly going into surgery. You were going into psychiatry, and that's sort of how it was differentiated. So this was the way we grew up, and it really was preached. We resuscitate them to supernormal levels. We give more crystalloid, and the more we could give, the better things are going to get. And we did that for adults, and we did that for pediatric patients. And then David Notrick and I moved down to Houston to do some training, and we met this heretic, a crazy man. I mean, really, this guy Maddox said, "You're killing people. You're doing it all wrong, and don't give them any fluid. They're shot. Don't give them any fluid." It was the nuttiest thing we ever heard. And he went on to describe this popping of the clot, raising the mean arterial pressure, and increasing bleeding. And he suggested to us that we actually were the cause. We were the enemy. We were actually the cause of all the horrible things that befell these poor trauma patients in Houston, Texas. And the damn thing about it was he was right. He was right. It's been proven to be right. And it's actually not just adult patients. It ends up being true for pediatric patients. We created some of these consequences that led to terrible morbidity and even mortality in the pediatric patient. We led to those consequences, and we started working through the basic science to decide where we were causing the problem, and we were causing disruptions in the coagulation cascade. We were causing lung injury. We were causing edema, and all of these things led, even in the pediatric patient, to morbidity and mortality. So the concept of a damage control resuscitation, well worked out, started from there, moved very quickly through the rest of the country, well known in Arizona and Arkansas and Houston. How does it apply to the pediatric patient? This is what I stay up and think about at night. I think about, do these principles apply, and when should I give blood? Should I give blood instead of crystalloid? What do I need to do if I think the patient needs a lot of blood? How do I do a massive transfusion in a pediatric patient? And then, is there any way to be a little bit smarter about it, a little more precise about when to give blood and how to limit the blood that I end up giving? So those are the 3 things I'll touch on, and I'll try to be very practical and just and tell you now. The punchline kind of is there's not a whole lot of data to answer these questions. So I'll give you what little I've got, and then I'll give you sort of how at least I begin to think about it. First one is, what do I do about, I was going to strike the pose. What do I do about transfusing? When should we transfuse? There is very, very little data. Any pediatric critical care folks out there? So in the critical care literature, really, there is one good trial called the TRI-PICU trial that looked at septic pediatric patients and looked at transfusion thresholds of 9 grams per deciliter as opposed to 7 grams per deciliter, and found that there was really no difference and that you could give a lot less blood and you could use 7. And yet, the Brain Trauma Foundation guidelines for pediatric patients say transfuse at 10, and there's not a lot to guide you there. ATLS, sort of our at least what should be our standard, still says give crystalloid. Still says you got to give 2 big boluses of crystalloid to replace half of a blood volume of crystalloid before considering blood. And the horrible thing about that statement in that chapter is I wrote it. No, I mean, that was dumb, right? It was dumb. But the problem is that they made me write that because there was not enough compelling evidence out there to say that a damage control resuscitation had the same benefit in the pediatric patient that it did in the adult patient. And without the compelling evidence, we were not allowed to make those changes. I think when you get the 10th edition, you'll start to see that come out, and it'll start to drive us, and that'll help us as we think about our pre-hospital resuscitations. But that's what ATLS says today. And the problem with not having the data or not really pursuing the data very much is that we get away with it. We get away with it because not a lot of pediatric patients, and pediatric patients, this is obviously a continuum. The 15, 16-year-old physiologically acts like an adult, and you get down to 2 or 3, that's a different animal, and the neonate's an alien. And so in the pediatric patient, it is very rare that they die a hemorrhagic death, that they die of bleeding to death. That's very uncommon. The most common cause of injury from trauma is a CNS injury, and they die of that. And so we get away with it. We don't have this problem a lot, and that probably is what has prevented us from doing really good research in the area. There are some physiologic differences that I think you have to acknowledge. The vessels are more reactive. I'm also 51 years old, and I've been teaching fellows for so long that I have no adrenal glands left, so I produce no epinephrine or norepinephrine. And my vessels, because of all my vices, some of which I demonstrated at the blackjack table last night, my vessels do not constrict. And so when I lose a drop of blood, my heart rate's going to go up, my blood pressure is going to go down. My pediatric patients do very different. They have this incredible systemic response to injury. They squeeze their adrenals. It squeezes the medium part of their arteries. They increase their systemic vascular resistance, and they maintain a blood pressure. So they hold on to blood pressure. They hold on to blood. They don't get multi-system organ failure the same way that adults do. And so we just don't see the consequences to it well. And there's not very good established transfusion thresholds for the PEDS patient. There is some evidence that giving blood at a lower level probably does help the neurologically injured patient, and that's the most common patient that we see. And then those that have to have transfusions end up doing worse. Well, that's not a big surprise. So this is not an Arkansas Razorback advertisement. This is our lab. And this is exactly what we're trying to figure out in the lab, is at what hemoglobin level does the brain end up losing oxygen carrying capacity, and do you get hypoxic in the brain with a brain injury? And so we're working on that, but we don't, I will say we don't yet have an answer. I think we have some clues that suggest that that level is probably the same in brain injury as it was in sepsis, and that the transfusion target threshold should probably be about 7 grams per deciliter. So here, practically, I told you I'd try to be practical. Here's what I'm going to do about the initial resuscitation and when to give blood. I am going to strive to never give crystalloid. I'm going to strive to help my pre-hospital folks not give exuberant boluses of crystalloid. I think the ATLS, the present chapter in ATLS is wrong, and I think you probably should either give maintenance fluid, or you should be giving, if you are hemorrhaging or exsanguinating, you should be giving back what they are exsanguinating. I think crystalloid should be avoided. I'm going to transfuse electively once the shooting's stopped and we're back in the ICU. I'm going to transfuse electively. My target trigger is going to be 7 grams per deciliter and not the 9 to 10 that had previously been suggested. And then we're going to try to gather or create some data to demonstrate why the physiology of the pediatric patient would make that work or not work. The next question is, what do I do when the patient needs a lot of blood? What do I do about a massive transfusion in a pediatric patient? Well, you've got some unbelievably good data in the adult world that sort of guides you here. It tells you who needs a massive transfusion and what the results of a massive transfusion are. And I think that you should read this, you should understand the science behind it, you should understand what some of the limitations may be to this study, but it still is excellent data. And the question is do we follow it very well in pediatrics? And the answer is absolutely not. This study demonstrates that we're incredibly variable in how we transfuse, in what triggers our massive transfusion, in the ratios that we try to achieve, and that most of it is sort of made up by the people at the scene, either in the ICU or in the trauma bay. And so there's a call in here for multi-center trials and some better understanding of this kind of data. So practically, here's what I do. I have a weight-based massive transfusion protocol. I think it doesn't make sense. If you're using the blood as the trigger to give the blood, it doesn't make sense to exceed a total circulating blood volume. And so you have to break it into sort of different groups. So we break it into the small, medium, and adult size group. We're going to strive for a 1-to-1-to-1 ratio of cells, plasma, and platelets. We're not going to achieve that usually, but in the striving, we're going to get mostly there. For right now, we're going to use adult triggers for when to start our massive transfusion. And I think groups like Dr. Notrika's Atomic Multi-Center group, this is the right thing for them to take on and to look at maybe what are the field triage criteria to begin a massive transfusion protocol. I think this is the perfect thing to do a multi-center trial. I demonstrated this to you earlier. This is actually sort of the graph that demonstrates that as blood loss goes on, that the systemic vascular resistance goes up, cardiac output is maintained, and blood pressure is maintained. And that's a big physiologic difference between the adult and the pediatric patient. The next thing is I'm going to try in the resuscitation, after the massive resuscitation or during the massive resuscitation, to try to not be such a squirrel about just giving a bunch of stuff because I've got it, because my blood bank can send me a bunch of platelets and plasma. I'm going to try to be purposeful in giving what the patient needs. And I'll tell you why I think that's even more important in the pediatric patient. Again, great data from the PROMIT study. There are some suggestions as it's been analyzed for pediatrics specifically. Does it all make sense? And there's some evidence there that maybe all the results aren't completely applicable in the pediatric patient population. And then Mary Edwards took some of the data from the conflict in Afghanistan and with Tuggle looked at that and decided that, interestingly, that giving a balanced transfusion in that patient population didn't always decrease mortality, and it didn't perform the same way as it did in the adult patient. Again, suggesting that there's probably something physiologic there that means that there's a difference. And I think, to me, this makes perfect sense. But I think the cautionary tale is that study's good and it elucidates a mechanism of trauma-induced coagulopathy and how to try to prevent it with a massive transfusion protocol. And I think what you have to do in peds is not say, well, there's no study in pediatric patients and therefore it's not applicable. I think what you have to do is start to look at the pediatric patient and say, is there something about their physiology, their anatomy or physiology, that would make that study not applicable? And I think you have to find that difference, and only if you find that difference should you not apply best practice to them. So I think you have to, I think that's really the way we should go about that. So does that data exist in peds? Yes, it does. And again, the younger you are, the more seen in an age-dependent way. These factors are different in their concentrations in the 2-year-old than they are the 7-year-old than they are the 17-year-old. And as you get more towards 17, you act like an adult, and so that those principles fit. As you get a little bit younger, these things happen, and we don't see the same degree of coagulopathy. And probably the trigger of that coagulopathy is different. We don't see it as high, we don't see it as early, and we see it more commonly associated with brain injury, and the mortality associated with it is higher than that in the adults if they have trauma-induced coagulopathy. So it does seem to be a little bit of a different animal. The mechanism behind it is not well worked out, and probably most importantly, it's never been shown that treating that coagulopathy actually improves outcome in the pediatric patient. So there's something more to it. I think the answer probably lies here. Don't tell them, but I think the difference really is it is about the brain in the pediatric patient, because the injury is not an exsanguinating injury that damages the endothelium. It's probably not a shock and a reperfusion injury. It is probably a coagulopathy induced by fibroblastin release from the brain injury that does something to the endothelium, and that's a different mechanism. I don't know the answers to these things yet. My real point is that just throwing the kitchen sink at them the same way that you do the 17-year-old or the 27-year-old or the 57-year-old may not make the same sense. So here's, I think it's a little bit, well, I think it's like this, right? I think it's like this. I think when you just throw the sink at them, I feel good because I'm driving somewhere, but I'm not real sure where I'm going. And I think that's really the problem with throwing the kitchen sink at them and not being targeted or precise in your resuscitation. So conventional testing in pediatric patients has been shown not to tell the whole picture. And to me, some sort of biologic testing of the coagulation makes the most sense to me. So for me, it makes sense to begin the same way as I begin in an adult, and then test at some point and figure out what the specifics are that I'm missing in the pediatric patient and try to be precise in my replacement of that. We've begun work in looking at replacement of specific factors and seeing if we can stop that trauma-induced coagulopathy in the pediatric patient and seeing if that makes a difference in their outcome. And just like in Arizona, here's part of my problem with it, is I sit in the middle of a state of about 2.7 million people, and it takes 3 hours by ambulance to get from the corners, which are the other populated parts of our state. 75% of our patients come in transferred from somewhere else, and they've gotten, despite my effort, they've gotten a lot of crystalloid. They've gotten a lot of blood. They've not gotten plasma because nobody's got it. They've never gotten they've never seen platelets. And so they come in some variable degree of coagulation or disruption of their coagulation cascade. And so for me, it makes sense to not just throw the kitchen sink at them, but to stop, test biologically, and replace specifically what they've got. We do use the adjuncts, and those are for you that have the slides or on the webinar. You can use those at least as our guidelines for where we start with some of those adjunct therapies. I think there is beginning to be some data that outlines the efficacy and safety of some of these adjuncts in the pediatric patient, although they may not have been tested yet in trauma. They've got other trials in which they demonstrate safety and can be used. Practically, here's what I'm going to do with things like TXA, and I'm going to give TXA if the biologic testing demonstrates that my patient is hyperfibrinolytic. So to me, it just makes sense to treat it like we do an adult and then test later and then retreat based on that. So the evolution of fluid resuscitation in the pediatric patient has been this in my career. It's squeezing on the bag of the deadly crystalloid, giving a ton of blood as fast as we can, giving component therapy, and now I really think it is being targeted to what they're missing specifically after the initial resuscitation with the biologic testings like with ROTEM and TEG, and then replacing those and gathering some data about adjuncts to see if I can give less blood in that patient population. So I'm going to give less. I'm going to transfuse at a lower threshold. When they come in directly from the scene, I'm going to start the massive transfusion based on adult triggers. I'm going to try to work with David and the pediatric group and define from the field what those triggers look like a little bit better and be more precise about when I do it. I'm going to give adjuncts according to the adult triggers until we have data that says that I need to do it differently. And then when the dust settles or they've come from a long way and they're sort of deranged already, I'm going to test them with some sort of biologic test, a ROTEM or TEG, and I'm going to replace them specifically. So that's sort of my algorithm. And then I'm going to get out and try to talk to anybody that I possibly can and about giving less less crystalloid. And I think if we could do that in the pre-hospital and the referring hospitals, I think we'd have a lot less of this derangement in their coagulation by the time they get there. And hopefully next time, if I'm fortunate enough to be asked back, I'd like to come back and share some of our data on transfusions and transfusion thresholds with you again. So thank you very much for your attention.